Be now explaining to you regarding rheumatoid arthritis, which you need to compare with rheumatic arthritis, which is found in children. One of the very fundamental differences would be that in rheumatic, that would be non-erosive arthritis, whereas the current topic that we are going to study, you are not only going to have erosions, but you could even in the later part of the disease have periarticular osteoporosis. So let us discuss a case-based scenario related to this particular disorder. I'm going to describe a female patient to you because as autoimmune disorders are relatively more common in women, but make no mistake, there is a possibility that he might even describe a postmenopausal women here deliberately to make you think in terms of other kinds of arthritis as well, including osteoarthritis. One of the highlights of this disease would be involvement of the small joints of the hand. Which are the joints that are hurting when you will ask the patient, and normally we have an app available for doctors or practicing doctors where you can actually key in and mark the joints which are involved in this person, because you ultimately need to work out how many joints are involved in these patients, and most of the time you will notice that this disease is bilaterally symmetrical. For example, if this lady is going to point towards proximal interphalangeal joint involvement of the left side of the first finger, that is the index finger, then she's going to point out to the contralateral joint of the index finger on the right hand as well. So bilateral symmetrical is usually the manifestations that is seen with this disease. As I highlighted, it's mainly going to be the small joints of the hand, and even the wrist joint can be involved. Well, the description will be given by the patient as inflamed joints, redness, and obviously pain. And when you touch these joints, they are definitely gonna hurt. As I highlighted, this disorder is gonna be bilaterally symmetrical. In contrast, when it comes to rheumatic arthritis that is seen with group A beta hemolytic streptococcus, you will notice that you have a migratory polyarthritis involving the large joints. In rheumatic fever leading to rheumatic arthritis, the arthritis jumps from one large joint to another. For example, today if it's the ankle joint that is swollen and the child will be walking with a limp, the ankle joint on the left side is swollen, there's a possibility that after 2 days this swelling will just disappear magically, and that's what the mother is going to say, that the swelling came suddenly overnight, disappeared suddenly, and then there could be opposite side knee joint getting involved. So the arthritis jumps from one large joint to another in rheumatic, but in rheumatoid it's going to be bilaterally symmetrical primarily for the small joints. The range of movements, you see, we can flex and extend our fingers. The range of movement of joints will definitely be affected, and lots of these patients will have difficulty in, let me say, holding a toothbrush or just getting ready to office because of the morning stiffness component, which might persist for a duration of 1 hour, and then as the day will progress, the manifestations will subsequently reduce. In fact, these patients might start using painkillers initially, because you see, anybody is having pain anywhere in the body, a person will go to chemist, purchase any kind of routine XYZ painkiller, but then the symptoms are persisting, and the moment the effect of the painkiller will go away, the swelling, the redness and the tenderness in the joint will come back. The symptoms of these patients decrease obviously with the painkiller, but also decrease with activity. So when you read these manifestations that I've written, you have to think in a question related to rheumatoid arthritis. Now you will also have to count how many groups of joints or how many joints overall are getting involved, because if you are going to be having less than 4 joint involvement, then we are going to call it a oligoarticular arthritis. On the other hand, if it's going to be at least 5 or more than 5, then I am going to call it a possibility or a diagnosis. I mean, I have not confirmed that it is rheumatoid arthritis as of now, so we'll talk about antibodies. But assuming the fact that this person is having a positive RA factor and a positive anti-CCP antibody, that is cyclic citrulline peptide antibody, if you have more than 5 joints involved, we are going to call it a polyarticular rheumatoid arthritis. Now, lots of time the question might actually just give you this profile and then say, what is the hallmark presentation? As I've explained, it's obviously the small joint involvement, but in MCQs, he may not write the word small joint, and he might actually write what I'm writing before you at the moment, that is flexor tenosynovitis. What I'm trying to explain to you here is that traditionally, most examiners, they try to make things a little difficult for you because obviously it's a competitive exam. So the early manifestation, or I would say the hallmark manifestation of this disease would be that the grip strength, I mean, this lady will say that I feel as if the power in the hand is reduced. It's actually not a reduction in the actual power because muscle strength is normal. It is just that the range of movement is substantially reduced. And lots of time, the concept of trigger finger, especially in orthopedics when it is taught, they might say trigger finger can be related to rheumatoid arthritis as well. So the basic point is flexor tenosynovitis means the range of movement is substantially reduced. the grip strength of the person is reduced. This will obviously aid in diagnosis. I'm not saying that this is a short feature that will confirm the diagnosis. It's overall presentation of the patient, because this is a multi-system disorder. I mean, majority of us tend to focus only on the joint component in rheumatoid, but in actuality, in internal medicine, you will notice most of the questions of rheumatoid arthritis would be for extra-articular manifestations. So therefore, in the subsequent slides, when I will talk about the extra-articular manifestations of this disease, that is what I need you to pay mainly focus to. Please remember, when it comes to extra-articular manifestations, you could be having even eye involvement in these patients. I'll describe them serially from top to bottom, but I would personally, from a medicine perspective, highlight the fact that joint involvement part you read even in orthopedics. Maybe some part might be discussed even in pathology as well. And you are anyway familiar with the small joint involvement, except for few tidbits that I'm highlighting extra over and above the traditional information. So guys, per se, this is going to be the joint involvement, and then this is an example of a erosive arthritis. So in this image, which was actually given in the exam also, you can notice two things. One, you can notice the ulnar deviation of the hands. And along with that, you can definitely notice the deformity in the fingers, including the deformity in the thumb, that is called as a Z-line deformity, right? Rheumatic is an example of non-erosive arthritis. This is erosive. There's a pannus formation, then there's going to be damage to the cartilage, and even in the later part, even the bone part can be affected. So periarticular osteoporosis, I mean, the very peculiar term. You read osteoporosis. Periarticular osteoporosis is always read in the literature with respect to the current topic. Let's have a look at a couple of deformities that can be seen, though I'm very sure you are aware of them from orthopedics, but I still have found people making mistakes. So let me just zoom it in. Well, the first one is very characteristic, but we still need to focus on certain core issues here. The core issue that I want to highlight here is that I am pointing at the DIP, the distal interphalangeal joint. Then I'm pointing at the PIP, the proximal interphalangeal joint of this person. So you will notice that when it comes to the proximal interphalangeal joint of this person, there is definitely a extension. But as you move towards the DIP component, there will be a flexion present. Now continue looking and compare this with the second finger or the second image that I've shown. This could be in the same hand in a different finger. So, I mean, you could be having a swan neck deformity and a Bhutanese deformity in the same person in different fingers of the hands. Now, you will notice the fact that when it comes to proximal interphalangeal joint and then when it comes to distal interphalangeal joint, here the situation is reversed. Earlier, the words that I said was PIP was having an extension. I repeat the statement you can see on the slide at the moment. PIP is having extension, but if you look at the Bhutanese deformity component, the PIP of the patient is rather having a flexion. So at the moment, it might look easy for you. What's the big deal? But in the exam, when he's going to write no flexion extension for the proximal and the DIP joint, lots of people tend to mix this up in the exam and they might actually miss the statement. He can interchange the information also. No? The bottom line is the interchanging should not occur. So you need to keep your mind very clear for swan neck deformity. There's gonna be a PIP having extension and the DIP having a flexion. If you get that, just invert the data and that would be Bhutanese deformity. I have usually seen that people messed up on this particular question, in which you will notice that there is no extension at the PIP. When you're looking at this image, all you're noticing is a flexion which is occurring at the distal interphalangeal joint of this patient. Well, by profession, this person could be a wicket keeper, this person could be a goalkeeper, this person is actually having a defect which we read even in orthopedics as mallet finger. Mallet finger is due to avulsion of the extensor tendon related to the distal interphalangeal joint. You would have lots of time, seen MS Dhoni when he was playing at the peak of his career. He might be when he's batting, or if you are just following cricket very avidly, you will notice lots of time his fingers were strapped up. That's because you see when he's taking up or catching a fast ball from a fast bowler like Bumrah or anybody else, I mean the fast ball when you need to grab, there's a possibility that there might be an avulsion of the tendon related to the DIP and therefore there would be a flexion defect occurring. Or for that matter of fact, all goalies, if you are a football player, I can say that when somebody's taking a penalty shootout, right, the guy who's taking the penalty shootout, he's gonna hit the ball as hard as he can. Now imagine if you are the goalie and you're gonna grab onto the ball, there's a distinct possibility that the velocity and when you're applying force, they could definitely be a mallet finger occurring. So profession wise, mallet finger would be relatively more common in sports persons, especially a goalie in a football or wicket keeper in a cricket. So they have definitely given images where I have actually seen people messing up between all these defects. Though they're taught very well in orthopedics, but I would still like you to never ever mess up between a mallet finger versus a swan neck deformity. It might look straightforward when all three are in comparison, but otherwise I have seen very brilliant chaps making mistakes. So you definitely need to, get the orientation right. Then in the exam, he had also highlighted this deformity that I have now mentioned, that is Z-line deformity. And apart from that, ulnar deviation of the hands is obviously relatively easily available or easily visualized. When it comes to Z-line deformity, there are three defects that I want you to understand, and these can itself be the part of the question. In fact, majority of questions that will come on this topic will be talking about maybe two choices on extra-articular manifestations and two choices related to the orthopedic / medicine, what we're discussing at the moment. And obviously one of them or many of them can be correct or can be wrong. That depends on the perspective. That depends on how he's presenting the data. Like in Z-line deformity, here we'll talk about subluxation of the first metacarpophalangeal joint. So keep the words in your mind very clearly. There are two things happening here. There are two subluxations written in literature. One is going to be the subluxation of the first MCP, and second is subluxation of the distal radioulnar joint. Now he can obviously make it proximal, then that can definitely get, he might say what's the incorrect statement or what is the correct statement about Z-line deformity. The messages are that there are two subluxations, one at the first MCP, second at the distal radioulnar joint. And along with this, the third defect that is present is hyperextension. You can see that there is a hyperextension of the interphalangeal joint. So if you get these words right, and I would say imprinted in your brain, and I would suggest you to note these points down with me, then I think that there is a fair amount of possibility that you are not going to forget it. Apart from this, don't be under impression that only hands or the joints of the feet are not involved in rheumatoid arthritis. I agree that it's the hand manifestations which are frequently given, but in some questions he can mention about joints of the feet as well. Now, I want you to understand that in this particular case, if he says which joints in the feet are involved, your answer would be given as metatarsophalangeal joints. Immediately, the moment you read the word MTP, metatarsophalangeal joint, the first thing that comes to your mind is features of gout. Remember, like you are comfortable with the fact that in acute gout, it is first MTP that is involved. I want you to be comfortable with the fact that in rheumatoid arthritis, it is the first metatarsophalangeal joint that can be involved. And apart from these patients might even be having a flat foot. Well, what is the disadvantage of a flat foot? The disadvantage is that these people will not be able to generate traction on the ground. So especially if somebody is to be recruited into the armed forces, somebody is to be recruited in CISF or maybe in CRPF, those guys have to do a lot of running, right? If somebody is having a flat foot, he may not be able to generate the sufficient amount of traction and he might actually fall or injure himself during the training component. So especially when you are recruiting young guys into forces, people with flat foot are rejected, and pes planus can be associated with rheumatoid arthritis. Cervical spine is highly vulnerable. You see, one of the important reasons why it disqualified a young guy who was having diagnosis of rheumatoid arthritis, and nowadays even girls are recruited into armed forces because of gender equality issues, and you would be reading and seeing about female battalions. Now, suppose you are the doctor, right, and you are doing medical for a female battalion, and you have this lady who has been diagnosed with rheumatoid arthritis, or you notice some defects which are suggestive of rheumatoid arthritis, you have to declare a medically unfit. And when you declare a medically unfit, she would, maybe ask you, doctor, how can you make me unfit? I cleared the physical test. You see, I want you to understand this point that cervical spine is very vulnerable in patients of rheumatoid arthritis, and lots of these patients, they have pain, they have redness, so they may not only take painkillers, but they might even start using homeopathic medicines, Ayurvedic medicines, steroids, and start even doing yoga. Yoga is good. I might criticize Ayurveda, I might criticize homeopathy, etc., or mixopathy stuff. But when it comes to yoga, yes, they have documented the fact that if you do all those stretching exercises, they cause release of endorphins. And those endorphins will reduce the pain component. So whenever somebody with a rheumatological disorder is coming to you and you are advising regarding doing yoga, absolutely no problem. But you have to be very pertinent with respect to the fact that you see your cervical spine, ma'am, is very vulnerable. There should be no stress on your cervical spine. Like in yoga, they make a person do a headstand. So that headstand can actually be detrimental to the health of the cervical spine. And in fact, I can explain this by describing a case to you so that you will understand my point relatively better. This is a young lady. She was diagnosed with rheumatoid arthritis by you. You did antibody tests, which are turning out to be positive. So she subsequently asked you, can I do yoga exercise? Or she never asked you, can I do yoga exercise? And in those circumstances, though you had told her to take care of her neck, she started taking these classes online from instructor who's not well trained to handle persons with rheumatoid arthritis practicing yoga. So he told her to do some neck exercises. I mean, obviously, if you have ever tried yoga, they do all these neck rotation exercises, etc. So this lady was also doing it. After doing this yoga exercise, she started having some weakness in her arms, weakness in her shoulders. So she thought that maybe she has exercised after a long duration. That is why the weakness component is there. You see, like you guys are doctors, most of doctors have a sedentary lifestyle. Like if I ask you to do running for 1 kilometer at the moment, after 500 meters, you might be very fit, right? But because you have not exercised for a long period, you might get breathless and you might start getting tired. Same here. She's thinking that I did exercise after long duration, so she's having this weakness in her arms. But by evening, the weakness in the arms has worsened to the level that now she's having weakness in her legs also. And unfortunately, after let me say 1 day or 2 days, this lady became wheelchair bound. Imagine the amount of disability that I'm telling. A lady with rheumatoid arthritis did a headstand or neck rotational exercises, though you had warned her to not to take stress on her neck, or she never sought your advice as a lot of patients won't. She has become a wheelchair bound patient. Well, what really happened? This was actually a case that you will encounter in orthopedic/medicine that was asked in AIMS exam, and they maybe got a case like this of a lady with RA, doing exercise and then ending up with quadriplegia. Well, as I highlighted, the cervical spine is highly vulnerable. So let's give a technical name to it because that's a non-medical way of explaining to a patient. The technical word for you and me is that there is a compressive myelopathy. In this lady, there was a atlantoaxial dislocation, which results in compressive myelopathy, and therefore the important tracts in the spinal cord are compressed. And well, this lady may never recover. With best of physiotherapy or efforts of yours, you may not have a recovery in this case because you know that once spinal cord gets damaged, then the recovery part is really a very long drawn effect. This should be remembered specifically from the exam perspective. I would like to rate this as an important statement. Atlantoaxial dislocation is read by you in pediatrics with I hope you can recall that, Down syndrome. Just like you are comfortable from pediatrics that atlantoaxial dislocation is common with Down syndrome, I want you to remember that atlantoaxial dislocation is also seen with rheumatoid arthritis and may even be encountered in ankylosing spondylitis. In fact, in ankylosing spondylitis, guys, the spine is rigid and osteoporotic. It might just break. So people with rheumatoid arthritis, guys, right? Rheumatoid arthritis is going to be seen in both the genders. Gender-wise, it is more common in females. Ankylosing spondylitis is more common in men. People with these arthritis cannot be recruited into the forces. This is the basic point that I'm trying to tell you. So whenever you are examining a person and you especially have to recruit that person into the forces, not only cardiac issues have to be ruled out, like I've explained to you, ruling out cardiomyopathies, even these defects like autoimmune disorders like rheumatoid ankylosing spondylitis must be ruled out. I shall now be explaining to you the extra articular manifestations of rheumatoid arthritis. That's where pure internal medicine data comes in. The number one to be answered is rheumatoid nodules. Please do not mix them with rheumatic nodules. I'm talking about rheumatoid nodules. These are non-tender and would be noticed on the extensor aspect. So you can see them on the dorsum of the hand or over the olecranon process. Please remember the fact that in rheumatic, there is a positive ASO antibody associated. Here, there would be a positive RA factor and an anti-CCP antibody positive. When it comes to rheumatic nodules, they are gonna be present only on the extensor aspect, but never are gonna involve the lungs. Rheumatoid nodules. Do remember the fact that when it comes to rheumatic nodules, they are only gonna involve the skin, but when it comes to rheumatoid, lung involvement can be there. These are inflammatory nodules, so they can break down also. That can result in development of exudative pleural effusion, and that will give some leverage to the examiner to introduce the lights criteria. I've discussed them in the topic of pleural effusion, but they help to identify exudative pleural effusion. And why I'm saying exudative is mainly because it is inflammatory nodule breakdown. There is also possibility that these nodules can press on the peripheral nerves, contributing to mononeuritis multiplex. The term mononeuritis multiplex basically explains to you that multiple neuropathies are occurring concomitantly. Like I can just give an example here, though you don't need to note down the next information. You are already aware of what I say next. You see, posterior tibial nerve involvement can cause tarsal tunnel syndrome. If there's a nodule pressing on the posterior tibial nerve, tarsal tunnel syndrome. If there are nodules which are pressing on the median nerve, then the pressure on the median nerve would contribute to carpal tunnel syndrome. Normally, we read about these deficits so many times in a career, but I am teaching you a patient who could be having combination, concomitant tarsal tunnel and carpal tunnel. Why? Because these nodules could be present anywhere. So if they involve the peripheral nerves, then combination of these two can be seen. So just like in a, in a multiplex hall, multiple movies are running. Similarly, here the term is mononeuritis multiplex. That means multiple peripheral nerves are involved simultaneously. Apart from this, he can mention a skin manifestation, livido reticularis. This would mean that you would be able to see some very fine blood vessels in the skin, and these blood vessels would be giving a very characteristic fishnet appearance. I hope you recall fishnet appearance on immunofluorescence study of skin biopsies, a feature with pemphigus vulgaris. In the same spirit, I want you to remember that fishnet appearance for blood vessels on the skin. You see, I'm not talking about a biopsy in this case. I'm just saying this is the physical skin appearance. So do read the question carefully, whether he's asking you fishnet for skin appearance or whether he's asking you fishnet appearance for immunofluorescence studies of a skin biopsy, because obviously the perspectives are different. You could also be having some purpuras, which would mean palpable bleed in the skin, and even ulcers in the tip of the finger can be noticed in these patients. Now, because multiple informations came simultaneously, so to set the house in order, what I'll do is I'll try to explain manifestations of rheumatoid arthritis patients from top to bottom. The joint part I've already highlighted. I'm mainly focusing on the extra-articular manifestations. You could be having eyes involvement. Traditionally, in most autoimmune disorders, you will read about eye involvement of uveitis. Like for example, in sarcoidosis, you have non-caseating granulomas. They cause uveitis, but you do not read about uveitis in rheumatoid arthritis. Instead of uveitis, what you read here is keratoconjunctivitis sicca, which is the commonest ocular manifestation of this patient. Otherwise, you could even be having a scleritis component or episcleritis, which could be written. Worst can be even a scleromalacia perforans. So bad news here in a sense that you could be having a damage pretty substantial to the sclera, that there is even a perforation occurring. Very classical terminology, even taught in ophthalmology as well. This question has been asked multiple times, ocular manifestation of rheumatoid arthritis. He basically wants you to think in terms of uveitis, whereas it's going to be scleritis, though the commonest one is dry eyes, keratoconjunctivitis sicca. Because this damage can occur even in the salivary glands. So saliva production is compromised, so xerostomia developing in the patient. Then in the cervical spine, I've already highlighted the problem of atlantoaxial dislocation, which will occur in future. So you need to rule them out from getting recruited into forces or police, for that matter of fact that they won't be able to do their job and will hurt themselves. Now I will describe what's gonna be the lung manifestations of these patients. He can either write pleuritis, because this is inflammatory nodule causing a pleural rub, or multiple nodules. And when they break down, you could be having blunting of the costophrenic angle on a chest x-ray of these patients, primarily because there's a pleural effusion component coming up. Then I'll describe the cardiac involvement in these patients, which is highly important. People tend to neglect it, but please be very careful here. You see the nodules are occurring in the outermost layer of the heart. So you will read about chest pain and ST elevation, that is pericarditis. If the nodules occur and damage the myocardium, well, even heart failure can occur. The bad news is the valvular region that can be associated is mitral regurgitation. I've anyway explained to you the fact that with almost any condition, if heart is involved, then the most common valve involved is always the mitral valve, and the lesion seen is always regurgitation. The reason I've also explained is primarily that mitral valve in our body operates under the highest hemodynamic stress, and therefore the lesion that is associated is also going to have a high valvular gradient or pressure gradient. The incidence of ischemic heart disease is dramatically increased in women or men with rheumatoid arthritis. The bad news is that because there is a hypoxic damage to the heart, even tachyarrhythmias can occur, and that can contribute to sudden death. I want to tell you that in these patients, especially after the age of 45, there can be a higher incidence of accelerated atherosclerosis. If the question says what is the leading cause of death in a person of rheumatoid arthritis, especially after 45 years of age, then the atherosclerosis part can definitely be increased. In my earlier discussions, I have told you that even in SLE, you could be having accelerated atherosclerosis. So cardiovascular mortality is one of the important reasons of why a rheumatoid arthritis patient can die. In SLE, it will depend upon whether it is treated or untreated. As I've explained, in SLE, if the person is not treated, active lupus, kidney will fail because the person never took treatment. If he has taken treatment, then you will give him immunosuppressive drugs like methylprednisolone, for example, in exacerbations, and steroids are immunosuppressive drugs. Now what will happen? Infections. So it's a very thin line. Rheumatoid is all about that fine balance you need to obtain, because if you give too much of steroids, you have infections. You don't treat a person of SLE, there could be kidney failure. Same here for rheumatoid arthritis, though for RA we do not use steroids. Lots of orthopedicians actually prescribe intra-articular steroids in rheumatoid arthritis. That's a very temporary feature and is usually not recommended. So we will talk about the treatment of this condition, but I just want to give you an insight. It could be eye, salivary gland, atlantoaxial dislocation, then could be lung involvement, cardiac involvement in these patients, and heart disease can definitely be a big killer. I'll go down a bit and now highlight on another body organ, that's going to be kidneys. Whenever there is any autoimmune disorder and if kidneys are involved, then what kind of lesion of the kidney would be seen? Your answer would be given as MGN, membranous glomerulopathy. In fact, when I've discussed the kidney topic, I've highlighted that MGN can be associated with any autoimmune disorder. So you read MGN even with Hashimoto's. You read MGN with even SLE. You read MGN even with current topic rheumatoid arthritis. You will also read about secondary amyloidosis here. You see, amyloidosis can always occur with chronic inflammatory disorders. As you've studied in pathology, double A variety of amyloidosis is what I'm talking about. Then even genitals can be involved. The bad news is this person can be having hypoandrogenism, and therefore in the later years of life, or if the diagnosis is made even younger and person has not taken treatment, there could be issues with respect to conception in a female patient. Hematological manifestations can also be anticipated. Because it's a chronic disorder, it's a long-standing disorder, you will be getting anemia of chronic disease. You would have done this MCQ multiple times, that what is the type of anemia in anemia of chronic disease? It is normocytic normochromic anemia. So the question will simply say what kind of hematological manifestations can be seen. It is an anemia and it is a normocytic normochromic anemia that will ultimately manifest. Osteoporosis can definitely be seen. That's either due to disease process, and secondary, even the treatment of these patients can contribute to osteoporosis component. Then can be skin manifestation of purpura, which is one of the important features, in a sense that we tend to neglect the finding and it's given towards the end. Livedo reticularis, it's unlikely to be missed by a individual in theory if given in an MCQ as a choice, because you read it per se with rheumatoid arthritis has livedo reticularis. The error in livedo reticularis can be rather with respect to the appearance, because as I highlighted, I'm repeating that again. You are reading fishnet appearance or the gross appearance of the skin. That's gonna be livedo reticularis. You read a fishnet with immunofluorescent study of skin biopsy, it's gonna be pemphigus vulgaris. I would suggest you to draw this diagram by yourself, right? Starting from the eyes, go down to the genitals of this person. And if you get these manifestations right, you are bang on spot to remember the extra-articular manifestations. But the most common extra-articular is still not present in this particular diagram. That is why I've highlighted it separate, that the most common extra-articular manifestation is rheumatoid nodules. We actually get so much engrossed while studying this particular slide that rheumatoid nodules concept is forgotten. That is why I have highlighted it in advance only. Now, before I discuss the pathology of this disease, I want to say about two very interesting terms. One, you are familiar about Kaplan-Coaching for USMLE, but I'm talking about Kaplan syndrome. And I'll just quickly make you revise this with what is given in Bailey and Love for Felty syndrome. Both of them are related to rheumatoid arthritis, but these associations can be missed in a rush to do a question, which would be easy, but I've seen people messing up between the two. So Kaplan syndrome, you can remember from C, would be associated with Kohlberger's pneumoconiosis. On the other hand, when it comes to Felty syndrome, you would be having two more additions to it. That's going to be a splenomegaly, and then blood count that would be also added here. That's going to be neutropenia. From the pathology domain, you can read more from the pathology app, but I want to highlight that one of the important lesions that you read here is pannus formation. Well, what does pannus gonna contribute? It's gonna cause a synovial inflammation. So initial part of the disease is all about synovial inflammation, and the tenderness and the pain is mainly related to this part only. But as the disease progresses, that is when you have cartilage erosions, you have bone erosions, and the later part you would also read about periarticular osteoporosis. Whenever there's a bone erosion serially developing in this person, there will always be deformities present. Well, once this pathology takes its shape, once the disease process is on its way, he will ask you how to make a diagnosis or what are the criteria that can be used for making a diagnosis of rheumatoid arthritis. So I'm just creating a mnemonic here by the name of JSAD, which will help you remember how do we diagnose rheumatoid arthritis in clinical practice. This JSAD is not an official term that is given in the textbook. I repeat once again, neither in Davidson Harrison would you find the word JSAD. This is what I have just created to explain to you how would you make a diagnosis. The first and the foremost would be to document the joint involvement in these patients, and make no mistake, it could be small joint involvement, it could be large joint involvement also. You just need to note down. Either you can draw a diagram of a hand by yourself, put in PIP, DIP. You anyway know that you don't need to write PIP and DIP. You can just put markings on a image hand drawn of both the hands of a person. Just draw a hand like you draw in a nursery class for any person, and you can mark out the joints which are involved. So there is a distinct possibility that there is a person who could be having one large joint involvement. There could be even patients who could be having 2 to 10 large joint involvement, substantial disability. There's a possibility person might be having 1 to 3 small joints involvement. It could be 4 to 10 small joint involvement. SJ means small joint, LJ means large joint. So I hope you can pick it up. And then it could be even more than 10 small joints, both the joints of the hands. When you start counting left, right, it could be more than 10 also. One objective why I doing this activity is to obviously differentiate oligoarticular from a polyarticular variety, but more is the number of the small joints involved. Then it will give more credibility to the diagnosis. That's what I said. No, large joints may be involved, but small joint involvement in this disease gives credibility to diagnosis. Then alphabet S would stand for some kind of serological evidence given in the question. Well, there are two tests. One is gonna be RA factor, and second is this antibody, cyclic citrulline peptide antibody. He might write the word low titers, he might write the word high titer. So let me explain what he means by the word low titer. Your answer would be low titer would mean that the values are less than 3 times the upper limit of normal. On the other hand, whenever you read the word high titer of anti-CCB antibody, then it means it is more than 3 times the UL means upper limit of normal. So there's a distinct possibility that you have got a report from the lab. If it says high titers of RA factor, high titers of anti-CCP, the diagnosis is more credible. If it says low titers of RA factor and low titers of anti-CCP, it might still be a diagnosis. You will say suspect rheumatoid arthritis. I repeat that again. You see, if it's predominantly small joint involvement, let me say more than 10 joints, and the report says high titers of RA factor, high titers of anti-CCP detected, then the credibility of diagnosis is increased. On the other hand, if it is low titer, then the credibility, diagnosis is still there, but the credibility, or I would say I'll still rate it as a possibility of a suspect rheumatoid arthritis. Then we will also take up, in this case, acute phase reactants. There are two of them. One is gonna be ESR and second is gonna be C-reactive protein. ESR can be normal. That's very important statement that I'm saying, guys. ESR can be normal, CRP can be normal either in osteoarthritis or in rheumatoid arthritis. I mean, when you check out the scoring pattern, that is JSAT that I've created for you in a textbook, from a textbook, you will notice that in the scoring pattern, even ESR and CRP is included, and the normal values can also be given, and they are actually seen in practice. So the only arthritis or the only subtypes of arthritis where you get normal ESR and normal CRP is rheumatoid arthritis and osteoarthritis. They definitely can be substantially elevated also. CRP positive can also be there. Then D stands for duration of illness. I want to highlight that in a single consultation, you can never make a diagnosis of rheumatoid arthritis. Follow the patient serially over the next 6 weeks and see how many joints are progressively getting involved. It could be less than 6 week involvement. If it is more than 6 week involvement, obviously the diagnosis is given more credibility. There is actually scores given to all these parameters. Like let me say RA factor low titer will be given less marks, and RA factor high titer will be given higher marks. So if the total score on JSAT turns out to be more than 6, I'm not going into the scoring because it's a big table for each one of these, no, like small joint involvement, large joint involvement. It's properly mentioned, these many points for these many joints. So nowadays we have apps available. You download this app and for Rheumatoid specifically, and then you just need to feed in which joints are involved, acute phase reactant report, serological data, just key in, press on the submit button, and it tells you that what is the composite JSAT score. And I repeat once again, JSAT is not given in the textbook. I've just created that just to help you remember the parameters that are useful for identification. That's going to be the joint involvement, serological evidence, acute phase reactants, and the duration of manifestations. I shall now be explaining the workup of these patients with rheumatoid arthritis. The first test to be done is not to be answered as X-ray of the hand. You see, X-ray will definitely pick up lesions, but that might be very late when you get cartilaginous and bony erosions serially. It's mainly when the bony erosions will develop. That's when the X-ray will pick up the disease. I can definitely do MRI hand, and that can pick up evidence of synovitis. The inflammation signal will definitely be picked up. I want to highlight that early imaging that can be done in this disease is not a requirement of an X-ray. It's rather a MRI that would be sufficient to pick up the synovitis component. Now I will be doing the screening test for this condition, that is RA factor. RA factor is actually IgM class of antibody, so there is a distinct possibility that this test may be biologically false positive. BFP means this test RA factor can be biologically false positive in 5% of even normal population. So you can understand that if some test is gonna be positive even in ordinary population, it cannot be used as a method of choice, or I cannot call it investigational choice, or I cannot call it the best test for diagnosis of this condition. This can max be a screening test, but it's not going to be the investigational choice. The antibody that will be more accurate for diagnosis of this condition is anti-CCP. We can measure the titers also. Let's write down and practice the full form. It's always a good idea to practice the full forms of all the topics that you study. So I'm talking about anti-CCP, that is cyclic citrulline peptide antibody. The fourth test that I'm saying is usually not done in majority of cases. This is just for academic reasons that I'm saying that if you do a joint aspiration in this patient and then subject the synovial fluid on joint aspiration to a microscope examination, because it is inflammatory, you will be having a higher number of cells. The cells can range from 5,000 to 50,000 cells. In fact, initially, I mean, when the disease will start, there could be a predominant neutrophilic count and subsequently mononuclear cells would come. But these high counts definitely tell you regarding evidence of inflammatory process. Otherwise, normally the cells which are going to be present in synovial fluid will be in few hundreds, but in this case, it would be in thousands and even going up to 50K. If you do X-ray of the hand of this person, you definitely would be able to pick up erosions only in the later part of the disease, as I have highlighted. So what I'm writing in part number 5 is only for the sake of completion, that there would be a reduction in the joint spaces that can be picked up on X-ray, later part of the illness I'm talking about. And you can notice this peculiar term that I've been speaking, periarticular osteoporosis. Well, X-rays will not be able to pick up the initial stages is what I'm trying to highlight here. And once you have made the diagnosis on the basis of a composite score JSAT more than 6, with all these investigations chipping in and contributing to diagnosis, we are now ready for treatment of this chap. I want to tell you that nowadays non-steroidal anti-inflammatory drugs have no role in management of this condition. When I was a student your age, we used to study first give NSAIDs, then use DMARDs in the person. Now the concept has totally changed. He says that if you are gonna give NSAIDs to the person, you are just delaying the introduction of what is actually required, because after all it is erosive arthritis, so disease modifying drugs should be given spot on right from the initial diagnosis. Non-steroidal anti-inflammatory drugs do not have any role in management of this condition. You will notice a lot of orthopedicians advising or giving intra-articular steroids. They do cause improvement, but maybe the duration of improvement is only short limited for 6 to 8 months. Therefore, lots of these patients might actually be coming back, and the orthopedician, to save his practice, might actually tell the patient, okay, this injection will work only for 6 months, come back to me. So you will hear about these stories of rheumatoid arthritis patients getting multiple injections in their joints. But after all, this is not, this is just gonna, this is like extinguishing the fire transiently, or I would say partially. The fire is still simmering, the fire is still burning. You have not been able to suppress the inflammatory response completely. So therefore, in spite of giving steroids, the disease process will still be continuing. In these circumstances, I'll highlight it. I mean, this is what Harrison quotes. He says intra-articular steroids have no effect in rheumatoid arthritis on disease progression. If the deformities are to occur, they will continue to occur, they will continue to worsen. We will now talk about disease-modifying anti-rheumatoid drugs which are recommended for these patients, and the one that is preferred is methotrexate. While I'm writing it, you can understand this drug cannot be used in pregnancy. Like if there's a young lady with rheumatoid arthritis, she's getting married the next month, and she says, well, doc, should I continue with methotrexate after my marriage? I'll tell her, no, ma'am, if you have to conceive, methotrexate is teratogenic. In those circumstances, we might have to use what additional drugs. In fact, the drug additional that you will use in those circumstances will be hydroxychloroquine. In lots of rheumatic disorders, I'll be saying this: don't give particular drug. Like methotrexate is contraindicated in pregnancy, so we will have to switch over her to hydroxychloroquine. Methotrexate initially, when will be started in this condition, has an advantage that it is to be taken once a week as compared to any other drug that would be required on a daily basis. So if you look at the compliance component, I understand the side effect profile is also nasty, but still we will find, or you will find, that the compliance on the patient's part is relatively better as compared to other drugs, because the dosing frequency is relatively lesser. Other drugs which are useful for management of this condition will be rather having a more frequent dosing, that is leflunomide and levamisole. Now let us assume that I have given methotrexate already to the patient, but there is no improvement or there is a partial relief. So the options that I have at my disposal is to increase the dose of methotrexate in this person, though I'm increasing the risk of side effects also. I can then add drugs. So first step in these patients who are already on methotrexate not having a good response is increase the dosage, then add additional drugs. And here you will add sulfasalazine. Yes, the same drug that you study for inflammatory bowel disease, especially in ulcerative colitis. The third drug that you can add here is a hydroxychloroquine. I personally have seen good response with combination of these three drugs, and that is what is recommended. This would be called as triple therapy. Now, traditionally, you read about triple therapy with Helicobacter pylori, where you are going to be using two antibiotics like erythromycin, amoxicillin with a PPI. But today, we talk about triple therapy even in rheumatoid arthritis. The drugs are methotrexate, sulfasalazine, and hydroxychloroquine. These are the steps in the management of these patients. Start with methotrexate, the lowest possible dosage. Keep on incrementing or increasing the dosages proportional to the response that you're getting. I mean, if you are getting a subsidence of the disease activity, great. Otherwise, try to upgrade the dose of methotrexate. Additional drugs are hydroxychloroquine and sulfasalazine. We call it a triple therapy. You can use a mnemonic here as well, that is MSH, that can help you remember this relatively easier. Now, let us assume that the person is having a poor response even to the triple therapy. Then the option available before me would be to continue with the high dose of methotrexate. I mean, do not downgrade the dose of methotrexate, because you are handling a chunk of the immunity attacking the synovium per se. But along with this, I can be using biologicals also. See, biologicals are relatively more expensive. So most Indian patients, you would be writing triple therapy and they'll do very well. But yes, if the cost is not a barrier, then biologicals can be used for these patients. One of the important biologicals that you will always read about and is also useful for management of cytokine storm in COVID-19 pneumonia is tocilizumab. The other drugs which may be written in MCQs, you can practice from pharmacology or practice with me here, would be sertolizumab. You see, biologicals are the in thing nowadays. You will see lots of physicians, lot of practitioners writing biologicals for patients. Cost is obviously a hindrance if it's gonna be a poor patient. Then is abatacept. Then is gonna be even rituximab, the anti-CD20 molecule that you read even in management of non-Hodgkin's lymphoma with R-CHOP. additional strategy that is now being recommended is giving methotrexate contained with a high dose with tofacitinib. Well, tofacitinib is again gonna be asked from pharmacological domain because this is gonna be a JAK3 inhibitor, and JAK3 inhibitor, what it's gonna do is mainly inhibit the signaling of receptors of cytokines, because cytokines are the main culprits here related to the immune system. I'll just write the theory part here. I mean, if he says how does tofacitinib act, your primary answer would be it will inhibit the signaling of the receptors for the various cytokines which are involved in the disease process. Let's just quickly recap. What is your approach? Methotrexate forms the mainstay. That is why it's going to be answered by you as the drug of choice. Do not answer NSAIDs per se in management of rheumatoid arthritis, because I've explained to you the NSAID component has actually shown to as I said, you see, fire is burning and you are just suppressing the fire transiently, so it's or partially, so it's gonna cause a deep-seated damage. The erosive component that comes in once the disease occurs and once you get this ulnar deviation of the hand, or very peculiar terms might be written sometimes, like I'll add one more term here, like sometimes you will read regarding piano key movement of the ulnar styloid. In fact, that's an additional point that you can read up in the textbook or can remember here. The statement of mine is piano key movement. That's a later manifestation before the ulnar deviation of the hand comes in. Piano key movement of the ulnar styloid is a feature of your answer would be again rheumatoid arthritis. And you can notice, the deformity of the hand. So the ability to perform any tasks would be substantially hampered in these patients. The drug part is first we give methotrexate, then we upgrade to triple therapy, then we subsequently can add biologicals. That is if we are having a partial response, and we can definitely use a oral molecule, that is tofacitinib, which they love to ask from pharmacological domain as well. The topic is relatively a straightforward one. It is just that diagram that I made before you for extra articular manifestations going from top to bottom. Now, once you're done with this topic, I would suggest you to draw the diagram of extra articular manifestations starting from top to bottom by yourself, so that